Top health official is now ready to give his latest coronavirus update. Let's listen in.
Is with our sites or turnaround times, etc. So we believe that's a good, accurate number. 14-day positivity down to 7.2% as well. Next slide. Here again, you see an even lower 7-day positivity at 6.4%, bit lower than that 7.2 at 14 days. And then if you compare 14-day test positivity as we do each week, you can see that we've had nearly a 40%, 38% to be exact, decrease over the last 2 weeks. Again, positive sign about the trajectory of transmission across the state, seeing this in all parts, not just rural California, not just Northern California, but also the southern urban counties as well. Next slide. So we've been focused on hospitalizations, on ICU capacity for the last many weeks, nearly 2 months. We announced our regional stay-at-home order back in early December and been tracking this information throughout. So we've seen a nearly 29% decrease in hospitalizations for COVID over the last 14 days. 14,221 individuals in hospitals with COVID diagnoses as of yesterday. Additionally, good news, I've been sharing that we've been seeing about 4,000, upwards of 4,000 hospitalizations for COVID in a single day throughout the state. As of yesterday, we were in the 1,700 range for total hospitalizations, so more than half a reduction in new hospitalizations day over day compared to our peak. Similarly, this ICU number is a little bit harder to move. Individuals who need ICU level care with COVID often stay for quite some time. They're on ventilators, they're receiving other life-saving care to make sure they can get through the COVID disease. And so we're not surprised to see a slightly reduced, but still down number for ICU levels, now below 3,800 total individuals with COVID in our ICUs across the state. Number we're going to continue to watch, and I'll talk about in just a moment. Next slide. So here, a slide I showed a version last week to show where our projections are heading. We look at 4 weeks out, our total hospitalizations. This is not the ICU projections. I'll get to that next. We're anticipating that 30 days from now, so on the 4th of March, that we'll see fewer than half the number of people with COVID in our hospitals as we have today. Good news, continue to see that decline coming down. Of course, there are variables to this. This is based on conditions that we're seeing today. But if we start to see a reemergence of COVID in our communities, increasing numbers, these will change, of course. But based on today's information, our models coming together, we predict that fewer than half the people we have in hospitals today will be in hospitals 30 days from now across the state. Next slide. So a reminder that our regional stay-at-home order, which has been lifted statewide, really looked at our projections 4 weeks from now around where we'd be with our ICU capacity. Again, we built this around ICU capacity. It's not just the routine conversations on test positivity and rates of transmission or case rates, but we looked at this lagging indicator, but an important scarce resource across our state, which is ICU beds, ICU staff beds. But now we're seeing, when we do our projections as of yesterday, that 4 weeks out, we see Southern California, the hardest hit part of our state, that was well below zero in their ICU capacity, surging quite a bit in almost all of our facilities in Southern California. We now see that we project a 43.7% ICU capacity 4 weeks out. San Joaquin Valley, the next hardest hit region of the state, 35.1. 33.3 in the Bay Area, Greater Sacramento, also above 30 at 31.4. And Northern California, our least populated area, the area with the fewest ICU beds before COVID, still we project nearly 30% at 29.2% ICU capacity. Again, these four factors that you see on the right-hand side of this slide, current estimated ICU availability, community transmission rates, current regional case rates, and then the proportion of cases admitted to the ICU. Those are all the inputs that you can use to build into these calculations. You can see the historical data on past ICU capacity on the CDPH website. Later today, I'm not sure it's up quite yet, but this will go back to December 28th, the first day regions were eligible to be out of the regional stay-at-home order. Looking at the data, many of you will see some of those trends and how we landed where we are today, and certainly the information that went into lifting the regional stay-at-home order last week. We'll go to one more slide on this issue. Next slide, please. This slide, quite a detailed slide, but I think very useful to look at the various inputs to come up with our ICU projections. I used this last week, wanted to use it one more time to remind you that we look at the case rates in a region. We look at that R effective, that transmission rate, which, by the way, statewide is now well below 1. It's at 0.78 as of this morning. Again, good news. Want to see that continue to come down, stay below 1, so that we end up seeing a reduction, a contraction of the number of cases in our regions and statewide. These two inputs give us that projected COVID cases. We then use that to look at projected new admissions, then new ICU admissions, and then with a bit of a formula of where people are being discharged at the ICU, compiling all of that, looking at our total occupied beds, our capacity, to then come up with a percentage projected ICU beds available in a certain region. I know, pretty complicated, but for those of you who've been tracking it, I think important for you to sort of get under the hood a little bit, understand how these projections are made. Again, some people want this to be in a model. We think of this as a projection, not a model. We use current inputs to determine what's going to happen 4 weeks out from now. A little different than the various models that have been used throughout the pandemic to predict transmission and other rates of infection. Next slide. So we've been talking a lot since the beginning about testing, about case rates, and watching various moments of the last many months when we had, quote, surges in cases. But over the past month, 2 months, we've been talking more about variants. These are, as I've reminded you before, different, the same COVID virus, but where the genes, the sort of blueprint for how the virus behaves might have a mutation here or there. And some of those mutations are meaningful and create what I call additional stickiness, more infectiousness of the virus, or in some cases, not the case here as far as we know, but in some cases mutations can affect the way a treatment works, the way a vaccine works, or even causing someone to become sicker because they have a variant strain as opposed to the wild type strain. We're continuing to actively sequence the virus here in California, building up capacity to do even more. We're watching the West Coast variant that we talked about a few weeks ago. Here we're seeing over 1,000 total variants between these two slightly different mutations of the same West Coast variant across our state. We reported both in Southern California, parts of the Bay Area, Santa Clara in particular, where this variant was being found. Again, unclear about its exact role in either making people sicker because they have the variant strain, or its impact on things like vaccine or infectiousness. So stay tuned as we continue to learn more there. And then the UK variant, a variant that we first talked about, continue to see cases here in California, although not rapidly increasing in the number that we're finding, still at about 133 cases identified across 5 counties, largely in the southern part of the state. So we'll continue to watch this. I know many of us believe this is an important detail, watching not just do we have COVID in our state, helps us through testing, but this sequencing element, understanding what type of what type of COVID strain we're contending with, and will that change how we address and behave in any of our pandemic response elements. Next slide, please. So as we talk about case rates, we talk about the future projections, we look at things like the variant, it's an important time to talk about fundamentals. Masking matters. We've been talking to you since nearly the beginning of our pandemic response about the use of face coverings, surgical masks, for some, the importance of an N95 respirator. These are all different ways to protect ourselves, our communities, our households from COVID transmission. We know that one of the most powerful tools we have to reduce COVID transmission, they protect both ourselves as a wearer and others around us. And what they do is block or filter out the virus that's carried in aerosols. So what do you need to know different today? That we really want you to pay attention to the material that your mask is made out of. Some masks, more surgical masks or procedure masks, often the blue masks with the white ties. I have one here. Many of you have them or have seen them around. They're a high quality mask that does do more often than face coverings. They often come with a metal tab that you can firmly put it around your nose. Another important aspect is making sure that your mask covers both your mouth and your nose, that it fits snugly around your mouth and nose and around the rest of your face so that air doesn't easily move in and out of your masked areas. And then doing this and wearing a high quality mask consistently over your mouth and nose when you're outside of your home, when you're at work, when you're with other people that aren't in your household. But for some of us, and in high transmission communities, in households where it's hard to protect vulnerable individuals, those with underlying conditions, those who are older, those who frankly we're prioritizing to get vaccinated if they haven't yet been vaccinated, and even when they have, trying to wear your mask around them until we get our case numbers down much lower. It's a good way to protect yourself, but also loved ones in your household so that they can be protected from COVID-19. I often think about this moment as I think about the fourth quarter of the situation that we're in, now that we have a vaccine, that it's an important time to remind ourselves of these fundamentals, to remind ourselves to do them as much as we possibly can. I know in my own community, I see more people milling around, less masking than I would like to see, less masking than we saw maybe a couple of months ago. And it's a real opportunity to up our game on this point, to increase our ability to protect ourselves and our families and our communities at large as we try to move through the pandemic. So as you can, I know these have been politicized. There's been a lot of tense conversations about masks, but as we enter this sort of final period, do what you can to mask up and protect yourselves and your communities. Next slide, please. So the next part is really just talking about vaccines, and been on everyone's mind, certainly been the major work effort that I've been a part of, our team at the state, not just in public health or health and human services, but broadly the work of Secretary Yolanda Richardson and GovOps and many, many others, all across state government, partnering with county partners, other healthcare delivery partners, community-based organizations, to continue to build up our ability to get more and more Californians vaccinated. As we've said before, the only rate limiting step to vaccinating Californians should be the availability of the vaccine itself. We continue to work with the federal administration, the manufacturers directly, to understand what can be done to get more supply to California as we really build up our capacity. The Vaccinate All 58 campaign, really a partnership with all 58 counties, working to make sure that we do what we can to get every county, every corner of our state vaccinated. through our efforts. The announcement now, myturn.ca.gov. We talked to you about this before, a new state program partnering with certain counties as well, LA County, San Diego County now up and running, but really statewide, a program that you can go and try to understand when it's your turn, register to be reminded or notified when it is your turn. And in fact, if it's your turn to receive vaccine now in certain counties, San Diego, LA, later on, statewide, you'll be able to register and get an appointment. The nice thing about myturn.ca.gov is it's also an opportunity to seamlessly move information about vaccination into the state database so we can know who's been vaccinated and continue to make sure we're reaching all Californians to get vaccinated. It also helps us communicate to our federal partners at the CDC the level of our use of vaccines in the state. We've been working hard around the clock on the data issues, as you'll see in a future slide, getting more of that data in a timely way so that we can notify all of you. We can track our own efforts, make improvements as we go, and also notify our federal partners about the level of vaccines. So check out myturn.ca.gov, and we'll keep you updated on how this tool can really help us in our efforts across the state. Next slide. This slide is really one I've shown you before, what we call our epidemiologic curve, where infections from testing, as we get more information from our test volume, it comes in a little bit late, but we're able to attribute on a specific day when a test was taken so we can get a sense of how the disease transmission has gone. This is not that curve, but it's similar in a way. This shows our ramp up. So if you look on the left side of this graph versus the right side, those lower bar graphs versus the tall ones on the right, that's essentially been the ramp up of California's vaccination efforts day over day over the course of the last approximately 8 or 9 weeks since we started vaccinating Californians. Not surprising when supplies were low, when we had fewer providers administering vaccine during the holiday season, when we were in our most difficult, challenging surge, and those same providers in charge of vaccinating Californians were taking care of Californians in need of life-saving care at the bedside. But as we've come out of that surge, increased our ability, like the train picking up steam, you see that I'll remember a day right before we started our 10-day challenge. Back in early January, we were doing approximately 45,000 vaccines a day. We had a peak day of over 180,000 vaccines done in a day. More than 3 times, closer to 4 times the level of vaccination that we were doing in the early part of January towards the end of the month. So certainly picking up steam with that. Proud of the efforts and the work that the state team has done to work with our county partners, their tremendous effort to organize the vaccine work both at mass vaccination sites or other events, as well as working with the traditional vaccinators like clinics and hospital systems and others to get Californians vaccinated. Next slide. So I wanted to take a moment, and the last slide really talked about how we're beginning to speed up across the state, and all very good news, and thank so many leaders who've had a hand in helping us get there. But advancing equity continues to be one of the key efforts around our entire pandemic response, but also with vaccinations. And I want to start by talking about this notion that there's a choice that we have to make between speed in vaccinations and equity. This is not a choice. This is a false choice. We can do both. Equity, in fact, to achieve it with vaccination requires speedy vaccinations. We cannot wait long to vaccinate those communities that have been disproportionately impacted by COVID, those communities that may have historically higher hesitancy to vaccines and healthcare services, where access is not as robust as it is in other parts of our state, where the time when vaccines happen matters, that people who work long days on the front lines in essential places, who come home exhausted and tired, may need late night options, convenient options in other locations. So all of this is part of the speed that goes into an equitable distribution of vaccine. So as we work around racial equity, as we work to touch Californians who have underlying conditions or functional needs or severe disabilities, to make sure that we create touch points and opportunities to have vaccination be easy when that time comes. So looking at some key strategies, pay for performance, a sort of clunky healthcare term, which really means incentivizing people and paying them, those who are doing the vaccinations, to do well, do thoughtful vaccinations in partnership with communities in some of those hardest hit communities, supporting those vaccination partners to do work in communities of color, making sure that we're providing resources necessary to do the targeted outreach and engagement with community-based partners, the faith-based community and others, to make sure we're targeting the right individuals. We've talked before about using our allocation strategy to make sure the hardest hit communities receive vaccines sufficient to reach many of their population, and then using our ability to create non-traditional sites, as I mentioned, education opportunities, so that we can really put our best forward to get those who've been shouldering the burden of COVID vaccine in the right quantity, so we can really end this pandemic in some of our most hardest hit communities. This is something we'll continue to talk about. This is really part of what we've talked about with the blueprint. You'll remember our health equity metric, something that we built around focusing our testing, not just our testing supplies, but the result of those testing, the test positivity in hard hit communities, our lowest quartile healthy People's Index communities across the state. So continuing that focus on our health equity metric, building that into our vaccine strategy, and really pushing this forward with so many partners to make sure Californians are vaccinated in that equitable way. Next slide. Continuing on this front, public education campaigns focusing on use of trusted messengers, trusted professionals who can communicate effectively with communities that and populations that often have some degree of vaccine hesitancy, making sure we focus on in-language content with a degree of cultural humility that we expect for all of our healthcare services across the state. And we need to be laser focused here on the vaccine campaign, using ethnic media across the state to reach a lot of audiences that hard to reach because we don't always have material and education materials, in particular in language, using live reads, essentially providing scripts to individuals who can reach a number of folks across our state who maybe can't tune in to some of the English presentations or even some of our Spanish presentations, making sure that we touch way beyond the traditional languages that we often focus on, but to these 40 different ethnic outlets, 18 different languages.